Hi, I'm Dr. Brian Kaufman, a CLL patient myself and the co-founder, executive vice president, and chief medical officer at the nonprofit CLL Society. And I'm going to be talking about the BTK degrader BGB-16673 and its strong early CLL SLL results. What is the bottom line on this? Blocking BTK, Bruton tyrosine kinase, which is part of the pathway for the B cell receptor, has transformed how chronic lymphocytic leukemia is treated, but resistance can and often does develop. Rather than inhibit BTK, BGB-16673 destroys it, with about 2 out of every 3 patients responding. Who performed this research and where was it presented? Dr. Ricardo Perondo led an international group of researchers and presented an oral abstract on these encouraging results on the last day of the European Hematological Association's annual meeting in Barcelona in 2024, EHA 2024. Let's dig into the background. Chronic lymphocytic leukemia, small lymphocytic lymphoma, or CLL, SLL, was revolutionized when we began to understand that the cancer cells were dependent on their survival and proliferation on signaling through the B cell receptor, or BCR. Several medications have been developed to block this pathway, but by far the most impactful have been the BTK inhibitors, starting with ibrutinib and followed with acalabrutinib, zanubrutinib, and pirtobrutinib. These oral drugs have proved superior to all prior chemoimmunotherapies and have become the mainstay of care, prolonging life and offering patients who were previously out of options new hopes. However, CLL, SLL cells can eventually develop mutations that cause these medications to stop working. Finding new ways to block BTK when resistance develops would be a boon to patients. BTK degraders, such as the experimental BGB-16673, work differently. While they are still, quote, small molecules, close quote, which can be taken orally, they have a more complex structure. Instead of blocking BTK, which is an enzyme or kinase, they tag the whole molecule for destruction or degradation. The BTK is completely broken down. Essentially, its component molecules are recycled and used to build new proteins in the cell. They go through sort of the cell's garburator. The destruction, of course, leads to a full stop of the BCR signaling, which in turn leads to control of the CLL, SLL. Moreover, at least theoretically, cells that were resistant to other BTK blockers and patients who've had that problem, the efficacy should not be affected in those cases. So let's dig into the methods and participants. So this was an early phase 1 trial to look at the optimal dose and assess drug safety. Patients must have relapsed refractory CLL, SLL with a minimum of 2 prior therapies. BGB-16673 was dosed once daily orally. So what we really want to know is what were the results. So there was 42 patients with CLL that were enrolled. The median age was 70, so fairly representative. 39 were treated at the following dose: 50 milligrams for 1, 100 milligrams for 5, 200 milligrams for 15, 350 milligrams for 14, and 500 milligrams for 4. For treated patients, the median number of prior therapies was 4, and the range was from 2 to 8, so a tough group. And it included covalent BTKIs, where 95% or 37 of the patients had those. It included the BCL2 inhibitors such as venetoclax in 87% of the patients, or 34, and the non-covalent BTK inhibitor like pirtobrutinib in 10 patients, or 26%. This was a pretty tough group to treat. Of the patients who were tested, over half, 54%, 20 of 37 had deletion 17p and or TP53 mutations. 87% had the undesirable unmutated IGHV, and 43%, or 12 of 28, had a complex karyotype. These are all bad prognostic markers. The median follow-up time was only 3.3 months, so these are very early results. Let's look at the adverse events and dose tolerance. The maximum tolerated dose has not been reached. The most common side effects were contusions, seen in almost a third of patients, 31%. They were all mild. Fatigue, also 31%, all mild. And diarrhea, 26%. Low neutrophil count, 23%, but 18% had a more severe or grade 3 neutropenia or low neutrophil count. One patient had a transient emergent adverse event, or TEAE, consisting of grade 3 or severe hypertension. Interestingly, no atrial fibrillation was seen. 2 patients had adverse events that were fatal: septic shock and pneumonia. Neither were considered related to treatment. 2 additional patients had adverse events that led to treatment discontinuation: a subdural or brain hemorrhage and thyroid cancer. 1 patient had a dose reduction to a grade 2 or moderate and not dangerous arthralgia or joint pain. So we've learned about the adverse events and the dose tolerance. Let's look at the responses. 35 of the 39 patients, or 90%, remain on therapy. There was 4 discontinuations, 1 due to progressive disease, and the other 3 due to adverse events. Of the 24 patients whose responses could be assessed at the time of the data cut for this abstract, the overall response rate was 67%, with all but 1 response ongoing. Responses were seen at the lowest dose in previously patients treated with covalent BTK inhibitors, 16 of those, and a non-covalent BTK inhibitor in 2 of those, in patients with and without BTK mutations. So let me summarize and try to come to conclusions here. BGB 16673 is producing impressive results in difficult to treat patients who are running out of options. It worked at low doses in patients who were resistant to both irreversible, like ibrutinib, acalabrutinib, and zanubrutinib, and reversible pirtobrutinib BTK inhibitors. Though the numbers are small, the lack of atrial fibrillation is encouraging, as was the fact that 90% of the patients remained on therapy. The durability of the response is yet to be assessed, though the first few enrollees are more than a year out and are doing well. Degraders are a promising part of the future of CLL/SLL treatment, and not surprisingly, several other BTK degraders are in development, and CLL Society will be presenting more results on different drugs. You can access the link to the video on this, and the EHA abstract itself will be available at Preliminary Efficacy and Safety on the Bruton tyrosine kinase BTK degrader, BGB 16673, in patients with relapsed refractory CLL/SLL, results from the phase 1 BGB 16673-101 study. You'll find all that on the web. Stay strong. We are all in this together.